Hello. 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 Hello, Q.
Hi, Prof.
You okay?
Yes, I am.
Good. I'm just sharing my screen just to intro the invited guest. and immediately after that I will stop sharing so that you can share your screen.
Okay, Prof. Danelle will be sharing her screen for me.
Okay.
She'll be my mouse.
Okay. But the two
So
of
she
you,
will share. Yes.
will coordinate with each other, huh?
Yes, Prof.
Okay, no problem. Okay.
Thank you.
Okay. Tanel, are you set up to help Q?
Yes, Prof, I'm ready.
Okay, good. Okay. Hello, good afternoon, Ulindi.
Hi, Doctor. How are you?
Good, and you?
Good, thank you.
Thank you for joining. We'll start in a few minutes.
Perfectly fine. I thought I'd join a bit earlier just to make sure that all the technology works and
Yeah, tell me about it.
yeah, new world we live in.
Yeah, and now we are also learning. So we have had our fair share of difficulties over last few weeks, but yeah, we are trying to adjust.
Yeah, absolutely. So
Yes.
I'll just go on mute and then I'll wait for you to tell me
Yes.
when.
Yes, as I wrote to you in my email, the format will be I will intro you with the biosketch which you sent to me. Then I will invite Dr. Salie to talk, which will be about 25, maximum 30 minutes. After
Okay.
that, I will invite you to give your comments on the topic, which is quite, yeah, quite an interesting topic to say. And
Indeed.
yeah, after your comments, then I'll ask one by one my other three consultant colleagues to comment. And if then audience people have any questions, then we will answer that. So hopefully we shouldn't be
Perfect.
longer than 1.5 hours, 1 hour, 20 minutes. Okay. And
Perfect.
tell me, where are you best? Are you in Cape Town? Where are you?
Victoria.
Are you in Pretoria?
Yes.
Okay.
Yeah.
Okay. I mean, do you have a law practice in Pretoria as such?
Now I'm the head of delivery services for MPS.
I see.
So that is my current role.
Yes.
But yes, I've been in the medical legal field for many years.
Yes, yes. No, I saw that. And it's very interesting. I will intro also that you have worked in medical legal field in different spheres of our society. It's a very, very interesting journey.
Indeed.
You name it and you were there. Nursing, military, medical association, MPS, ethical. So I don't think there's any field of medical legal significance you have not been to.
It will be interesting to actually assess that. But yeah, I think I've seen it from all sides.
That's right. Yeah, that's right. Yes. And I mean, it was good to know you from this meeting. And yeah, we have adjusted to the new normal, and we are conducting our weekly academic meetings on Zoom. And then slowly, it so happened that we have started one expert invited guest for each meeting. And that's actually a blessing in disguise, because now who could have imagined last year or beginning of this year that I would be inviting you and you would be participating in our academic meeting?
Yeah, absolutely.
Yes.
No, thank you for inviting me.
No, no, no problem. No, it's our pleasure. So I'm just waiting for a few more people to join in. It's 5:02, another minute or so, and then we will start. So, Tony Behrman and you, do you work sort of together, or you in the different departments?
We work together, but we are in different departments.
Yes.
So the delivery services team is a new team that's in the process of being established in South Africa for
Yes.
MPS and for MPS members.
Yes.
And then Tony is working with Graham Craig on the other part of the MPS business.
Yes.
So in that respect, we are working together.
Yes. Yes. I think we can start. Yashoda and Selo, can we start now? Yashoda?
Yes, Prof.
Yes, yes. Let's start. It's now 5:03, and Miss Bertel is also here. So we'll start. Um, Okay, good afternoon, everyone. It gives me great pleasure to welcome you all, and also our special guest today, Miss Ulundi Bertel, who has lots of credentials to her credit. And I'm just going to quickly read through her bio sketch, which she sent to me today. Sorry. Sorry. And she has vast legal background for almost 3 decades, and she has worked in the medical legal field in various spheres of our medical and nursing fraternity in the country. Like, as you can see, she was part of the nursing council, then part of the army, state law advisor, also advisor to the medical association, and currently working in the legal department of the Medical Protection Society. So we couldn't have asked for a better invited guest for our talk today, which will be delivered by Dr. Q Salie, and it is on a very common topic, but has very important legal and ethical considerations. It's the issue of circumcision in children. So I welcome you, Lundi, and I invite Dr. Salie to talk. I'll just stop sharing my screen in a second.
Thank you.
Okay. Okay, Q, you can share your screen, please.
Okay, good afternoon, everybody. As Prof mentioned, the talk today will be on circumcision in children within the context of South Africa. Next slide, please. Male circumcision is the surgical removal of the foreskin, as we know. It is the most common surgical procedure performed worldwide. And having said that, there's a huge gap in ethical awareness surrounding this procedure, hence the decision for the topic of today's talk. We are going to have a look at the Children's Act, and we are going to define the requirements for cultural and religious circumcisions. We will also have a look at absolute and relative medical indications for this procedure. We will discuss then points for and against male circumcision, as well as ethical considerations. And then lastly, we will review some take-home points on the topic. Next slide, please. So with regards to the Children's Act, the minimum age for consent for treatment is 12 years of age. For a minor to consent to medical treatment, they require the maturity to understand the benefits, risks, social and other implications. And for surgical procedures, the minor needs to be assisted by his or her guardian or parent. Next slide, please. Minors who are 12 years of age and who are parents themselves may also consent to medical examinations and treatment for their child. They may also consent to surgical procedures for their child, again, with the assistance of their parent or guardian. Next slide, please. It is vital that when getting consent, one takes into consideration the maturity and intellectual capacity of the child. One also needs to consider the beliefs, wishes, and opinions of the parents or caregiver and their clinical circumstances as well. Considering all of these parameters may be quite conflictual. However, as healthcare providers looking after minors, we need to bear in mind that the child's interests are of paramount importance. Next slide, please. So with regards to social and cultural circumcisions, male circumcisions are allowed provided that you have proof that the child is at least 16 years old and Form 2 from HPCSA being signed. So on the following slide, there is an example of Form 2. Part 1, I'm not sure if you guys can see, so I'll just quickly go through it. Part A of Form 2 has all the personal particulars of the child. Part B has the details of the medical practitioner or the person administering the circumcision. And at the bottom of that page, it also has tick boxes that basically it shows or indicates that you have explained to the child the following: the nature of the circumcision, the different methods on how to perform the circumcision, the method that you will follow, any risks associated with the circumcision, any complications associated, and also any other implications or possible consequences. And then you also need to allow the child the opportunity to ask any questions. On the second part of that form, part C, that is the consent that the child signs, saying that all of the above that I've just mentioned has been clarified with the child. And then lastly, at the bottom, part D, is signed by whoever the parent or guardian is who is assisting the child in making the decision. Next slide, please. So with regards to religious circumcisions, again, male circumcisions under the age of 16 is prohibited unless it is for medical reasons. It also conforms to prescribed religious practice. It also needs to conform to a prescribed religious practice. And for religious circumcisions, Form 3 needs to be signed. So we'll go to the next slide and just have a look at Form 3. Again, Part A contains the particulars of the child. Part B contains the information from the medical practitioner or person administering the circumcision. And again, has tick boxes at the bottom, ensuring that you have explained the following to the person consenting for the procedure. And this again is the nature of the circumcision, the risks associated, any complications associated, and any other implications or possible consequences of the circumcision. Again, there needs to be a platform for whoever is signing the consent to ask any questions for clarification. Part C is the consent by the parent or guardian when the child is under the age of 16. Next slide, please. So with regard to absolute circumcisions, absolute indications for circumcision, one needs to be aware that there are very few absolute indications for male circumcision. These include the following: a tight phimosis secondary to balanitis cirrhotica obliterans, recurrent balanopostitis, smegmal cysts, or trauma that resulted in non-retractile scarred foreskin. Next slide, please. With regards to relative indications, one would now consider the prevention of urinary tract infections in boys with urological abnormalities. So it has been reported that there's a 3 to 7 times higher risk of urinary tract infections in uncircumcised boys. The greatest risk here is when they are under the age of 1 year. This is very popular indication for circumcision in healthy infants in the US. There is difference in the approach, as there is for most things, across the Atlantic. And in Europe, the policy is actually much stricter. Next slide, please. Further relative indications are certain urological conditions that benefit from circumcision. These include recurrent urinary tract infection and high-grade vesicoureteric reflux. Next slide, please. So points for circumcision include the following: easier hygiene, reduced risk of urinary tract infections. There's also reported a reduced risk of some sexually transmitted infections in men, protects against penile cancer. Next slide, please. It is also, it reduces the risk of cervical cancer in female partners, prevents balanitis and balanopostitis, and prevents phimosis and paraphimosis. Next slide, please. Points against circumcision. So obviously it's the pain, which you'll be able to pick up on the baby crying, the facial expressions, and also the torso rigidity when they're infants. Increased episodes of upset are reported with inadequate analgesia, which is also important to note. Next slide, please. So if pain and distress are significant enough, it may be classified as trauma. And if this distress lasts for more than 1 month, the diagnosis then progresses to post-traumatic stress disorder. It has also been noticed that some infants don't cry much at all and remain quiet following the procedure. This has been described as dissociation, which is worrisome in its own right. There has also been some suggestion that such severe pain and distress may negatively impact the bond between mom and baby. Ultimately, it has been suggested that a male who has been circumcised as a child is more likely to react with terror, rage, or dissociation when confronted with situations interpreted as threatening. Next slide, please. Circumcision in male infants has been described by some as a neurological castration due to the sensory input loss. It reduces sexual gratification and may possibly also lead to sexual dysfunction. Next slide, please. On to ethical considerations. Many debate as to whether the autonomy of the minor is actually safeguarded, as circumcisions are often performed due to the cultural and religious requirements of the parents or guardians and not necessarily that of the infant or child. One can therefore argue that the child cannot effectively give informed consent for the procedure. Again, even though the age of surgical procedures is 12 years old, are we actually taking into account the psychological and not just the chronological age of the child when obtaining consent from them? Another ethical dilemma here is cost. Can South Africa, as a developing country, actually afford the hospital admissions and theatre time for elective circumcisions, let alone the complications and prolonged hospital stay should a complication then occur? Next slide, please. Another interesting consideration is how female and male circumcisions are viewed. One can argue that the law may be sexist by protecting girls and not boys, as female circumcision is by no means allowed under any circumstances. And so we pose the question, can one justify circumcision for any reason other than absolute medical indication? As the topic of circumcision is an ever-evolving ethical dilemma, we as healthcare providers are required to keep our finger on the pulse. Of importance is the counseling for all parties involved, the parents, the caregivers, and also the child. In addition, we need proper documentation prior to the procedure to protect ourselves from unforeseen legal challenges. And lastly, we need to remember and take into consideration what is best for the child at all times. Thank you.
Juanita, that was an excellent presentation, very short and to the point, and you have raised those pertinent questions for which we are looking for answers. And I will invite now Ms. Ulunde Bertens to give her thoughts about legal things, legal issues, ethical issues as related to circumcision in children in our country today. Thank you, Yulindi. Floor is yours.
Thank you very much, Prof. Yes, that was very really a very good presentation. I was before the presentation, I was actually very interested to see if you pick up on the points that is usually problematic in circumcision. I think maybe just to set the scene, I'm just going to share some slides that now I do apologize. They are, I tried to get them in the right MPS format, but unfortunately I came up with a hybrid type of slide that, so it's apologies for that. So I'm just going to share my screen and just take you through some aspects that I want to highlight that you have touched on, but I do think that we maybe need to discuss in a wider context when it comes to ethical and legal considerations. So let me just find the right screen.
Yeah.
Apologies, okay, let me just try and see if I can go into presentation mode. Hopefully, okay. It doesn't matter. I think it will be fine the way that we do it now. So the first thing that I want to point out is that it was very good to start, to look at the Children's Act, but one must always remember that the Constitution is actually where most of the rights that we see and that we address in any medico-legal dilemma actually stems from the Constitution. So the Bill of Rights is usually the starting point because that is the document that informs, or the rights in the Bill of Rights are what informs, like for example, the Children's Act, PIA, POPI, the National Health Act, etc. So they are all what we call constitutional laws or constitutional legislation because they are the result of rights that have been included in the Bill of Rights. Now, I've listed a number of rights there. The first one is Section 12, which deals with the right to bodily and psychological integrity. That is typically the human right that underpins informed consent. So it links up with both a constitutional right, a legal right, as well as an ethical right. When it comes to interventions or medical interventions, we also, another right that is relevant for the topic under discussion is Section 15, which relates to the freedom of religion, belief and opinion. Very importantly, Section 27, which deals with the right of access to healthcare, and especially you will all be familiar with the right of emergency healthcare, and Section 27.3, which says that in an emergency you may not refuse medical treatment. Then probably the most important one, which is the right of protection of children, the rights of children in terms of Section 28, and that is the right on which the Children's Act is founded. So the Children's Act gives effect to the rights of children in terms of Section 28. So I'll address that in a little while. Also, the right to language and culture in terms of Section 30, and then Section 31, cultural, religious, and linguistic communities, the right to protection of those. So you can see that from a constitutional perspective, you often have more than one right or several rights that can apply, and very often it can happen that these rights are actually conflicting, and that makes it even more difficult to make it, to decide when it comes to justification and whether interventions are justified in particular circumstances, because there could be more than one right that you need to consider. For now, I'm going to focus on Section 28, which is the rights of children. And in terms of Section 28, children have the right to basic healthcare services and must be protected from maltreatment, neglect, abuse, or degradation. What I want to emphasize here, and this is in future, and I always say this when I do CPD talks or when I do, if I write an article or anything like that around children, is this is the most important right to know when it comes to children. So whether it relates to circumcision or whether it's any other treatment involving a child, Section 28.2 of the Constitution says, and our Constitutional Court has confirmed this on numerous times in various judgments, that a child's best interests are of paramount importance in every matter concerning the child. So that is the mantra that I instill on healthcare practitioners, that at all times it is the best interest in that matter. And you did touch and you did bring that out in the presentation. But it's not always clear as to, in a particular situation, what does the best interests of a child mean? And I think that's an aspect we can discuss a bit later, perhaps. So in respect of the Children's Act, as I mentioned, Section 28 is the Bill of Rights, and the Children's Act gives effect to Section 28 of the Bill of Rights. So that is the law that explains and sets out what the Constitution means with best interest of the child. Now, there's another thing aspect that I want to highlight and point out, because I've realized over the years that very often healthcare practitioners do not know that there are actually two effective dates for the Children's Act. And the first date is the 1st of July 2007, when the first part of the Act came into being, and then the 1st of April 2010, when the second part the remaining part of the Act came into operation, and that was when the regulations were finalized. Now that is important because in our courts have decided that an Act without regulations is actually, it's almost impossible to enforce. And that is why it's important to note that most of the provisions are actually came into effect from the 1st of April 2010. I just want to explain, and this is an aspect that you would have seen from the forms that you went through, is that it's very important to understand that there are always three elements to informed consent. So information or knowledge, capacity or appreciation of the child or the patient or the user in terms of the National Health Act, and then also the acquiescence or the voluntariness or the agreeing of the procedure. So those are very important to consider when it comes to the treatment of any child. Now, you correctly pointed out that Section 129 deals with consent to medical treatment and consent to surgical procedures, and what the requirements are in respect of age and capacity and maturity. The important thing here is that with surgical procedures, the child must be, must be assisted by a parent or a guardian. Hence, the forms that you refer to requires that assistance. What I do want to correct in your presentation is that the forms are not HPCSA forms. They are actually the prescribed forms in terms of the regulations. As I said to you, the regulations that were finalized on the 1st of April 2010. And there are other forms that actually needs to be taken into or taken note of as well. Form 34 and 35 deals with medical treatment and surgical procedures, and particularly when it's minors under the age of 12, or when it's child parents with minors and they themselves are children. I'm not going to go into that. There's also forms for virginity testing, and then correctly the forms for circumcision that you discussed. The key to circumcision that is often a debate or leads to a debate is the age of consent, because whilst Section 129 of the Children's Act says there's the age of 12, for circumcision, the Act actually prescribes that the age of consent is 16. So this is a very important distinction to take note of, because in terms of the Children's Act, circumcision of boys below the age of 16 is prohibited, except when these conditions are met, and that is where circumcision is performed for religious purposes, in accordance with the practice of that religion, or where it's for medical reasons on the recommendation of a medical practitioner. So unless those two requirements are met, circumcision is actually not allowed by law. The requirements, I'm not going to go through everything, all of what's written there. There are specific requirements in terms of the Children's Act as to who can actually conduct circumcisions on boy children. And what I need to point out at the bottom there is the last bullet point, is that the child can actually refuse the circumcision, taking into consideration the age, maturity, and the state of development. And that links up with what the requirements are that we see in Section 129 of the Act, the general consent requirements, if I can put it that way. So what we need to, you correctly pointed out that there are two forms specifically dealing with the consent to social cultural circumcision in terms of Form 2, or religious circumcision in terms of Form 3. When boys are over the age of 16, these are the requirements. It may only be performed if the child has given consent in the prescribed manner, and that is now in terms of the forms that you mentioned, or that you described, Forms 2 and Form 3. So Form 3 when they are over the age of 16, after proper counselling, and again in the prescribed manner as prescribed by the regulations. The following requirements must be met if the boy is older than 16 years, is that the parents or the guardian must assist the child. So that is similar to what we see in Section 129, and the boy's age must be verified. So you've touched on all the important aspects in respect of the Children's Act. I think what often, I'm going to stop sharing my screen now, because that was basically what I wanted to capture. The important thing that we often see, or aspect, is when we have conflict between the law, the ethics, is it ethically correct, and is it constitutionally sound in terms of the Bill of Rights. So I'll leave the topic there for some discussion or some views as to how you see it when you are confronted with these conflicts between law and ethics.
Thank you very, very much, Ulundi, for that legal background to us. I will just mention a couple of important practical scenarios we face with. For medically indicated circumcision, there is no issue at all. It's the local colored community. It's a culture to get their boys circumcised. So that's number one. Because father is circumcised, big brother is circumcised, the boy needs to be circumcised into inverted comma. That's number one.
Yeah.
And I'm sure you are well aware of the Isitkosa culture of circumcision beyond 16. But
Yes.
with the known morbidity and even mortality of traditional circumcision, some parents, including grandparents, are bringing their young, almost toddler boys to our hospital services for circumcision to prevent mortality or morbidity in future. And we are in ethical dilemma for both these situations. Are we doing the right thing? Are we protecting the interest of the child? Are we legally correct? So I think that's where this discussion keeps coming back time and again. So I don't know whether you want to comment now, and then I'll invite my other consultant colleagues to comment.
Yes, you're absolutely correct. And that is a question I've on numerous times over the years have been asked to comment on, what do we do as healthcare practitioners, as doctors, when parents bring in a young child that they want you to or they request a circumcision because they don't necessarily want to risk the child going to a traditional, for initiation to be done by the traditional healers. And that becomes very problematic. The reason being is that what constitutes the best interest of the child? Because do you then consider, well, are you going to say, well, if because that is often the question that doctors battle with is, well, if I don't do it, they go off to initiation school and something goes wrong, is it on me? Or do I have the duty to, even though it's not medically specific, that in order or rather do it now? And I would like to get the views of some of the other colleagues as to what they think and how they suggest that ethical dilemma be addressed.
Yes, thank you. Just one last comment. We also are faced with the same problem. We are the only service provider for more than 85% of the population in the central 1/3 region of the Eastern Cape province. So, and we have the capacity to do circumcision safely in the two hospitals where we work. And if we don't offer this service, then, as you said, they might go to traditional surgeons later. They will, the COSA, but the boys from the colored community, where will they go? They may either go to a general practitioner who may or may not have the necessary skills and may try and do it in an unsafe manner in his or her own surgery, again where the well-being of the child may be at risk. And the private health care is exorbitantly, prohibitively expensive. So people who are not on medical aid, my last understanding, say last year, it would have costed more than 30,000 Rand for a little boy to get circumcision in the local private hospital. So those are the problems we face with.
I think maybe if I can get some comments from
Yes.
some other consultants.
Yes. Now it is high time for me to invite one after the other consultants. So Yashoda, can you please comment and give your advice, please?
Okay. Thanks, Prof. And thank you, Ulundi, and thank
Sorry,
you.
just give me 1 second just to introduce you. Ulundi, Dr. Yashoda Manikchand is our consultant pediatric surgeon. She originally comes from Durban, but has been with us for last 3 years. So I'll just invite her to now give her comments. Please, Yashoda.
Okay, thanks, Prof. Thanks, Alundi, and thanks, Quanita, for that very informative talk. I think I learned a lot about the medical legal considerations, even having been doing this procedure for a while now. I don't think I have answers for all your questions. I think it is still an ethical dilemma, and it's a choice that we all have to make on an individual basis with the patient and with the parents. And I think we've highlighted already how important the consent is, especially in these cases. What I do want to say is that for the cultural and traditional ones, or religious rather, yes, I get that it is legal, and I still would encourage the parents, which I do, in our clinic, to wait till the child is at least 6 months old, because they come with neonates and infants. And in my opinion, an elective surgery, even a circumcision at that age, is too much of a risk under 6 months of age. So I would still encourage, even though it's legal, to wait more than 6 months to do the elective operation, the circumcision. And just to highlight that we choose to do the circumcision with general anesthetic, under general anesthetic. So Quanita rightly brought up the issues about analgesia and the moral and ethical considerations of doing these procedures with inadequate analgesia, because people assume that neonates and premature neonates can't feel anything because they can't say anything. So I think we have to advocate for them in that setting, because we should be advocates for the child and for his well-being. And she rightly brought up the trauma that is associated with pain at that level of pain at that age. So I just wanted to bring up those points for, the religious circumcisions, and maybe even more cultural now, like Prof, you rightly brought up, that it's becoming more of a cultural rather than religious request from the parents. Whether it is ethically correct and whether the child should have more autonomy when they are older, I think we're going to have to, like the rights were brought up and how they can, be on other sides of the scale. Unfortunately, with these religious indications, sometimes it is better to follow that religion, the religious indication, for the well-being of the child. So it is difficult, but at the moment, I think medical legally, we should offer the circumcision for religious purposes or cultural purposes, and of course, medical purposes. Yeah, so that's my comments.
Thank you, Yashoda. These are very pertinent and practical points. Ulundi, shall I invite the other two consultants to make their comments?
Please.
Yes. The next I invite Dr. Selo Machaya. Dr. Machaya is our homegrown consultant. He completed his full training of pediatric surgery in East London from 2015 onwards, and he has been consultant in our Department of Pediatric Surgery for over almost a year. So, Selo, please give your comments.
Hi, thanks for the wonderful introduction. And thanks, Q, for keeping it nice and short and sweet. I think I think the issue that we have has to do with deciding, is it religious or customary? Because I might be mistaken, I may not have picked it up thoroughly, but the law says religion and kind of highlights religion and doesn't necessarily consider your customs and your own family belief. And I think it's pertinent, Prof, that you had actually mentioned, like in a colored community, you can't say it's religious because that's what happens in the family, in the community at large. So in a sense, it would be cultural reason as to why they're getting the circumcision. So that's always a dilemma, because everyone always looks only at religion and doesn't follow the customs of that specific family. And as much as we try not to do any harm, and we definitely, that's not the point of what we're doing. It's to definitely be of benefit to the child and to the family. And the way we're trying to be of benefit to the child, for the family, is by offering the circumcision. A child in certain situations, if they're not circumcised, they're not considered part of the family, they get ostracized. So it's one of a vicious cycle where, luckily not as much for circumcisions, where I'll give it might be going at a tangent, but a child who may need blood, who's a Jehovah's Witness, and should the child receive that blood, the family would kind of cut the child out. So it's one of those things where you want to help the child, you want to make sure that the child benefits from your treatment and does not actually get repercussions from the family or from the society at large. So everyone in the community is circumcised. We are not intentionally going to harm the child. We're trying to actually follow the wishes and the practices of that community and the family. So hence why we offer circumcision. And the law kind of doesn't say that you can go ahead. It says religiously, yes. So if you're a Jew or a Muslim, good for you. But if you're a colored person who might not necessarily be following any religious antic, shame, it's good luck for you. So it's unfortunate, shame for that. The one nice thing that our anesthetists kind of enforced for us, which makes it easier for us to delay offering circumcision, unless if it's mandatory, is they've kind of pushed us to only doing circumcisions once the child is above 2 years of age, which they based it on the onus that the child's brain is still growing, and at 2 years of age, it's more safe for a safe anesthetic for a developing brain. But obviously, there's lots of research that came out that showed that that's not true. But to keep peace with the anesthetist, we kind of have also adopted that trend and actually try to prolong or delay the intervention of doing a circumcision, unless we are forced to do it, obviously. So yeah, that's my feeling about it. I actually find it interesting what Q was mentioning about female circumcision, which I've never been part of it. I've never witnessed one, but I know in certain parts of Central Africa, it's one of those customary or traditional things that they do. Not sure of what benefit it would be for a female, because it's been proven to have quite a lot of benefits doing a circumcision in a male, as Q highlighted. But in a female, I personally don't know what benefit that would be, as much as they say it might heighten sexual arousal or so forth. I'm not sure if it's of benefit. So that on its own is, I think, it's a discussion. Yes, it's because that's what I gathered that.
That's a separate issue. So let's not go towards female circumcision.
Yeah, I just
you will open the can of worms then.
Yes, I just found it interesting, and because I'd never even witnessed one, so that's why. Yes. Yeah,
Yes.
but I think for us, definitely we always go ahead if it's a religious or if there is a proven medical indication for doing a circumcision. And it's only when we have circumcisions where there's no actual medical indication for that, specifically in the colored community, where we would kind of prolong it after 2 years of age and try to accommodate them at that time. And being in the Eastern Cape and lots of kids having to go to the mountain for traditional circumcision and seeing the adverse effects of unregulated circumcisions, we've actually opted to try and encourage to have as many circumcisions as possible, because we kind of avoiding that, because as much as traditionally as well, it's one of those because traditionally they want to go to the mountain, they need to get that done as to prove their manhood, but we know the risks involved with going that path versus the hospital route, which may also have its own complications. We are not without complications, but it's lots, it's 10 or maybe even more times cleaner or even safer, and we can definitely deal with the complications earlier if they do occur. So I still don't know to this day as to what trumps what. Does religion trump culture, or the law kind of says, okay, you must listen to us and only do what we tell you, and whatever the family thinks is not necessarily so important, because that's kind of what is happening, where certain individuals or certain family members, before even coming to us, they're kind of encouraged to tell us that the child has recurrent infections of the foreskin. And as the child comes into the hospital, the child is healthy. There's no issue we seeing with the foreskin, but obviously the family is telling us that the child keeps having these recurrent problems. Should we just sit around and wait to see the problem, or should we act and try to prevent the problem from happening, which is where you would kind of have a situation where you're doing a circumcision on a healthy child with a relatively normal penis at that time without any complications, and would we have adverse effects in the future legally of saying we did a circumcision which was unwarranted at that point in time? Yeah, I think I've said enough, Shane, for today. Thanks, Prof.
Yes, Selo, thank you. Thank you for touching various aspects which had not been touched. I just want to make just one comment. I think that sense of belonging to a community is extremely critical, which Yashoda also touched on it. And I think that has a lot of significance, not only for the family, but for the proper growth of that boy and identity of that boy when he grows and becomes a man. And to me, actually, the law is unfair because it favors, as Selo said, and Yashoda also said, two communities, that is Muslims and Jews. And what happens for the other communities? Why doesn't the law not respect Kosa culture for boys younger than 16, culture of the colored community, or any other family where parents say that, no, I was circumcised and I want my boy to be circumcised. So that is the problem. So Ulundi, I think, Yashoda, do you want to make any additional comment? Yashoda?
No, Prof. I think
Okay.
it's important for us to just understand the law,
Yes.
so that we can make a policy for ourselves. Because I said 6 months, which is what I tell the parents. For me, that's a safer anesthetic. But Selo is saying 2 years.
No, I think those two are different indications, Yashoda.
Okay.
What you say is also correct for the religious circumcisions. And I also fully agree with you that we should not and we don't entertain religious circumcisions before 6 months of age. But Selo has said it more pertains to the cultural circumcision of the colored community boys and maybe even the Kosa boys who are brought to us early.
Okay.
Okay.
Sure.
So, do you want to make any comment? Because there's one more consultant I would like to invite, but you can make a comment.
I think that is exactly the dilemma that the law has created, and you know, I think when the law was written, when the Children's Act was written, I don't think all the aspects necessarily were considered. That's my personal view. Because even if we look at the headings of the different forms, Forms 2 and Form 3, now Form 2 reads consent to social and cultural circumcision, and Form 3 reads consent to religious circumcision. So that in itself is already confusing in the headings of the forms themselves. So what has happened, and what I know other practitioners do, is that they they basically apply the form, be it social, be it cultural, be it religious. So they actually go a bit beyond the strict boundary of the law, to still comply with the requirements of the law, if that makes sense. To rather have a proper consent form and make sure that the process was followed, than saying, well, there's a gap, so I'm just going to leave it, or I'm not going to I'm strictly going to follow the letter of the law, because I think this is a typical situation where the letter of the law is not clear. And you have conflicting situations. The one thing that I want to emphasize, because I was listening with interest with the six months versus the 2 years, and the one aspect that I think is very critical to this discussion is evidence-based medicine. So evidence-based, what is the best at the time for the child, for that particular child in that particular situation? And you are the experts. You know what that will mean. But the important thing is to say, well, and I like the idea of the guidelines, because we often find that where there is this gap between law and ethics, and we don't really have clear guideline or clear direction from the law, is that the best way to actually deal with it is to develop guidelines on institutional level or practice level, and to say, well, this is how we approach it. This is the criteria that we apply. These are the reasons for the criteria, because that forms part of the consent process in any event. So when you have that discussion in the counseling session with patients, then at least you have objective criteria that you can rely on to inform your decision. And because what I tend in the past to see is and I know a particular practice where it happened in Limpopo, where the parents would go to, say, one GP, and that GP would refuse the circumcision, and then they will just go to the next door GP until they find somebody who actually does it. And that's the other risk that we have, is that, if parents are adamant that they want to get it done, they will get it done. It doesn't make, it doesn't matter who does it, because at the end of the day, that's what they want. And I think that is where the advocate, the advocating for the child is so important. I'm not sure, and I'd be interested to know, how often have you experienced in practice where you've been able to convince parents not to have a circumcision or not to get the child circumcised, where you were able to talk them out of it? I mean, just out of interest, how often do you encounter that?
If I can answer that, Ulundi, I don't think I personally have tried to reason out any parent from getting circumcision done. Obviously, there are medical contraindications for circumcision, and we don't do circumcision in certain congenital abnormalities. So that is clear. But I can invite other consultants, Dr. Yashoda, Dr. Salie, or Professor Lazarus is also here, when I request him to comment, whether they have managed to sort of get a group of parents to accept, to convince them not to get their child circumcised.
Yes, in my experience, I haven't convinced them not to get the circumcision, but I've convinced them to wait.
Yes.
Until it was a safer operation in a bigger child.
Yes.
So that I've had a lot of success convincing them of that, even though, their religious beliefs is that it should be done as early as possible. We still managed to convince them that it is safer done later.
Yeah.
But I haven't convinced them not.
No, thank you, Yashoda. And Ulundi, if I can just sort of highlight or clarify, with respect to the adult urologist, I know for certain in town, very senior urologist, I think they still tend to do circumcision in newborns, and I knew of some gynecologists who used to do them as soon after birth as possible. They do it in the emergency unit under local anesthesia, which is completely no-no for us pediatric surgeons. And next, when I invite Professor Lazarus, he can comment, but it is my understanding, even though I don't have facts, almost like the Association of Pediatric Surgeons of South Africa have decided that it is not safe to do circumcision immediately after birth. But Professor Lazarus can correct me if I'm wrong. At least in my personal practice, as Dr. Yashoda said, I get plenty of requests at least once every month, mainly from Muslim community, that they want their little boy to be circumcised within 7 days after birth. And I give them the exactly same advice as Dr. Yashoda said, at least wait till 6 months of age when it is safer to do an anesthetic. So I will now invite Professor Colin Lazarus to give his thoughts, just a very brief intro because his intro can be very long. He is one of the most senior pediatric surgeons in the country, not only in town, and he was our ex-boss and mentor to most of us. And he's involved in academics and College of Medicine and association activities, etc. So Colin, please give your thoughts.
Thanks, Milind, always for the introduction. I just want to say that by way of introduction, I couldn't have been in a more contrasting environment than this discussion, with the excellent contributions from Q and Ulundi, your introduction, Selo, Yashoda. I mean that quite seriously, because about 6 years ago, I think it was, I chaired a meeting at the SARPS conference. That's our Pediatric Surgical Society. An hour was given to the discussion, which is exceptional for any conference. And I can only say that it was filled with acrimony. The folk who were present from the Pediatric Association and the Pediatric Surgical Association came from their own points of view, and they expressed them vigorously and somewhat emotionally. And in fact, there was only heat and no light, which I'd hoped would come at the end of the meeting. So this discussion now with this introduction has been so different. I don't think I have a lot to add to all that has been said. The thing is that with regard to our local community, it's so evident that the medical indications which we have and which Q had given us of one of the inverted commas absolute indications being recurrent balanoposthitis. Well, it's very, very difficult not to make that a very gray area. Inevitably, with a little bit of urine under the foreskin, there will be itchiness and irritability. And that can be produced at one end of the spectrum. And of course, there can be severe fibrosis at the other end. So it's not difficult for an indication to be found. But as at the nature of the community which Milind has outlined, that which we serve, it seems to me to be a cultural requirement, a requirement of the community. And I think that unless you are within that community, it's very difficult to seek to change the community's view on whether this is appropriate or not appropriate. Because, as Melinda's indicated, it's about that sense of belonging to a community. And that's certainly not one of the indications that the law has given us. So it continues to be a difficult ethical dilemma, particularly if, as Linda, you indicated, some of the indications given to us and some of the ethical things given to us by the HPCSA, etc., don't altogether make sense. I don't think I've added much to the conversation, except to say it's not clear, and I appreciate being part of this one today. Thank you.
Thank you very much, Colin. Thank you. Ulundi, I think I would request you to summarize, but I'll also ask our registrars to ask questions. But just one thing, Q, we call her Q, Juanita, and we were surprised that none of us was aware of Form 2 and Form 3. I mean, Dr. Lazarus and I have been working here together more than 25 years. And all these consultants, they add on to the expertise and the medical officers and registrars. But none of us so far, because we probably didn't look and we didn't know where to look for. So our eyes didn't see what our minds didn't know. But Q actually found those. And as you correctly advised, now we will have a discussion, and somebody will be given the responsibility to formulate a policy for the Department of Pediatric Surgery, and it may be revised from time to time. So we will have a document to refer to if it needs to be referred to. So please make some comments, and then I'll invite our registrars or medical officers if they have any questions.
No, absolutely. You know, I often find, even with forms 34 and 35, which is consent to surgical procedures by minors and minor parents with minor children, that there are very few practitioners that actually are aware of these, and they are prescribed. So they are required by law in terms of the Children's Act. So it was definitely very, very well picked up by Dr. Salie to find that, because I mean, if we say it's 10 years after they came, the regulations came into operation, and there are still many practices or practitioners that are not aware of the forms. So I do think, though, that the forms is a very useful guide, but it needs to be supported by proper guidelines. And I do think that the policy is a very right way to do. And because the one thing that, because it's such a gray area, and I think that is extremely important, is the recording of the justification for whatever the decision is that is being made. So if the decision is being made to, for instance, postpone or to wait, that proper records are kept in those instances. Or later, when a decision is made to do a circumcision, where it's not really, you know, you're not comfortable that it's medically indicated, but it is, as you said, the sense of belonging, which is actually also a right in terms of the Bill of Rights itself, but where you can actually, if ever asked in future, justify why at that particular time you made that decision to either do the circumcision or postpone the circumcision for that particular child. And I think that is the most important thing to, I almost want to say that is a takeaway from a discussion like this, is, so what, how will you implement this in practice? Because ultimately, you know, it is around the best interest of the child. It is weighing up risk versus benefit, you know, doing harm versus not causing any harm, and what that harm can mean not only physical harm, emotional harm, you know, pressure from society or acceptance in society. Do you, just a question for my own interest, do you ever involve cultural or societal leaders, community leaders in, you know, when you are dealing with a community issue like this, for example? Do you think there would be any benefit of involving community leaders in saying, well, you know, as a community, when you are approached by the community, what sort of advice or assistance can the community leaders in that particular community give?
No, Ulundi, we have never thought about that. I think I will have to discuss it with my consultant colleagues, and we will also take input and opinion from Professor Lazarus, and then we will proceed further, because we'll just have to tread very carefully. Once we start inviting non-medical people to participate in medical decision making, then we have to now, because we are all employees of the state, then we have to not only take permission from our own clinical director, chief superintendent, it comes to the provincial department and all, then it starts the ball snowballing.
Yeah, I know.
Because we ask for one document and then we may not get a reply for next 5 years. So
Yeah,
I think we will consider it amongst consultants and see, maybe we can just tap the community leaders without officially inviting them, or have some informal conversations, and then see how we go about it. But that's a good suggestion. We'll have to just take it very carefully. I will just invite Neha or Zwandile, one of our registrars. Anybody can just raise a hand and make a comment or ask questions. Neha, Zwandile, I see Helga, Wuyo, anyone? Okay, I see a couple of visitors from other departments. There is little time if you want to ask any questions. Otherwise, I'm just going to conclude this excellent meeting. No hands up? Okay, so without keeping you waiting, I really want to thank you for the time and the advice. And Q, excellent presentation. Thank you very much. It was really nice, and as Stella said, short, so we could have enough discussion, but you stirred the pot very nicely and brought out pertinent questions. And Ulundi, thank you very much, and we will remember to call you next time we have an ethical topic.
Absolutely, and thank you for the invitation. Sorry that I couldn't provide you an answer, but I think it's thought-provoking.
No, but see, in ethics, I don't think there is right or wrong. And I think that was the part of the discussion. My last request to you is, do you think I can share your PowerPoint presentation with my colleagues and the attendees?
Yes, I will just get it in the correct MPS
That's
format.
fine. That's
Or email it to you.
No problem. Thank you very much. Thank you. Okay, thank you everyone. Have a good evening, and wonderful to have you all and for the participation. Thank you, Lundi.
Thanks everybody. Have a good
Bye-bye.
evening.
Okay, bye-bye.
Bye.
Bye.
Thank you, Milind.
Bye-bye.